Hello again, Lindsay Fox, assistant professor in the Department of Emergency Medicine, also a medical toxicologist with the New Jersey Poison Information Education System. We're going to be talking about the implications of the COVID-19 pandemic on the already existing epidemic of opioid use disorder in the United States. Just a note, this lecture was initially given on March 31st, and then we realized that some of the audio was not loud enough for people to be able to hear. A little background, so we re-recorded just the first few slides. So what I'm going to do is I'm going to give you both the numbers from when we initially gave the lecture on March 31st, and then the updated numbers for now. In early May so that we can have some comparison, which actually is sort of interesting to see how much things have changed over the past several weeks. So we'll start by talking about the pandemic just in terms of the numbers, both how the United States compares to the rest of the world and then how New Jersey compares to the rest of the United States. And then our learning objectives for this lecture, we're going to be really emphasizing staff safety as being the first priority. This is true in the emergency department when we're taking care of patients with opioid use disorder or with COVID-19, but this is also going to be true really any setting that we're encountering people who could potentially have infection with COVID-19 or any place that we're taking care of patients with opioid use disorder. So this could be shelters, clinics. A lot of the issues are going to be similar as far as making sure that staff stay safe no matter what setting they're working in. And then we'll talk about the treatment considerations for individuals with opioid use disorder and how the current crisis might impact our how we want to think about things in the emergency department, as well as public health considerations related to this pandemic and the vulnerable at-risk population of patients with opioid use disorder. So the disease COVID-19 is caused by the novel coronavirus that emerged initially from Wuhan, China in late December 2019. Usually we think about it as causing a syndrome of cough, fever, shortness of breath. Can also present with GI symptoms. We're seeing additionally more reports emerging of a whole variety of symptoms. It's going to impact many different organ systems, can cause clotting, strokes, confusion. But one of the things that's going to be relevant for discussion here is that some of the symptoms might overlap with patients who have complications from opioid use disorder, either patients who have overdose. We might sometimes have a different difficulty distinguishing someone who is found down related to opioid overdose from someone who is critically ill, found down related to COVID. And then additionally, the symptoms of opioid withdrawal, things like diarrhea, abdominal upset, might be symptoms that we can see sometimes with COVID-19. So when we're thinking about this novel coronavirus, one of the things that's tricky about it is that it can be spread so many different ways and can remain on surfaces and in the air for hours to days. So it can live on plastics for several days, on stainless steel for 48 hours, cardboard for up to a day. And it's also been found that once it's aerosolized and really small sort of particles in the air can remain there for up to 3 hours and potentially still be viable. Most of the time, it's going to be not in the air for quite so long. Usually things will settle down onto surfaces, but that is a possibility, and that's part of the reason that this is spreading so quickly, and also why we really need to make sure that wherever we're working, that everybody is doing the best to stay safe and to decrease the risk of exposure while they're at work. So this pandemic has really impacted the world pretty dramatically in recent months. So this slide here has the data from Johns Hopkins from the initial day when we gave this lecture on March 31st. So at that point, there were not yet 1 million cases confirmed, and there had been at that point 42,000 deaths that had happened. So fast forward now to today, May 4th, and we can see that there are more than 3.5 million cases that have been reported and confirmed, and there are nearly 250,000 deaths that have been reported. So a lot can change in a month, and we're seeing that this has spread throughout the world pretty dramatically. We want to zoom in a little bit and look at the United States compared to the rest of the world. We can see that as of the end of March, when we initially gave this talk, the United States was experiencing doubling of the COVID-19 cases between every 2 and 3 days, which meant that we were really ahead of the rest of the world in a way that we didn't necessarily want to be, as far as how quickly the spread is happening and the number of cases that we have. And just so you can understand this, what this diagram means a little bit more, what this does is it takes that same data that's being reported by Johns Hopkins about the pandemic across the world and then separates it out by country and puts on the y-axis the number of days, or the time since 100 cases. This helps to be able to compare different countries that might have had their initial case experience at different times in order to be able to compare them directly to each other a little bit more easily on a visual scale. So this again was at the end of March. And if we look now to today, May 4th, we can see that the United States still at this point is leading the rest of the world in the way that we don't want to be. But we have noticed a decline in the how often we're seeing doubling of cases, which is good news. So social distancing has been effective in decreasing flattening the curve, we like to say. Now, if we look to the more local experience in New Jersey, we can, this is the same kind of diagram, but instead of comparing the United States to the rest of the world, it's comparing New Jersey to other states within the United States. And we can see that New Jersey was second only to New York in terms of the rate of rise of cases, as well as the total number of cases that we've experienced. And now moving forward to today, May 4th, we can see that that is still true. New Jersey is still second only to New York as far as the number of cases that we've experienced. But we can see that the curve has flattened both for New York and New Jersey, which is good news. So we're not experiencing as rapid of an increase of cases right now due to the effectiveness of social distancing measures. And coming again to the more specific situation in New Jersey, this is from, again, the end of March 31st. At that point, we had 18,000 cases that had been confirmed within the state and 267 deaths as of March 31st. And now, as of today, May 4th, we can see that there are 128,000 cases that have been confirmed within the state and 7,910 deaths. So that's been quite a rise in the past month, but we can see at least that the rate of rise is not happening as quickly. So hopefully we're moving in the right direction and we'll continue to find ways to slow the spread. Okay. So this comes back to what I think is the most important point that we all need to be emphasizing wherever we are practicing, is that staff safety has to be the number one priority. This is obviously important for all of us as individuals. We want to be safe and healthy. We want that for our colleagues. But this is also like a very important systemic problem. If we don't address staff safety before everything else, then there's the risk for there not being enough healthcare staff in order to be able to take care of the patients that are in need, and the whole system can collapse. So it's really, really important, above all else, that we protect our staff, particularly with appropriate personal protective equipment, which I know is a problem in a lot of places. And I'll be interested when we get to the Q&A session to hear if anyone wants to share what the situation is like where they're working. But I know that in many places across the country that staff safety is a problem, particularly with the access to N95 masks. So there's obviously some basic sort of measures that we can be taking, that everyone should be taking: washing our hands, not touching our face, sanitizing. And we need to be very vigilant about these practices, especially in the emergency department. If we remember back to a few slides ago, we talked about how long this stuff can hang out on surfaces. So it's just super important to really be obsessive about this right now. There's been a lot of discussion about what the appropriate type of PPE is. I think there's been different recommendations from different organizations. different hospital systems might be making their own recommendations. And I think that some of the recommendations are based on our scientific understanding of risk for transmission, and then some of the recommendations are based on real world considerations about limitations in supply chains. So I think that we want everybody to have the ability to protect themselves appropriately. So there has been some question about whether things like cloth masks or scarves can be used appropriately. And I'm going to go ahead and say I don't think that that's appropriate protection for healthcare workers. It might be appropriate for the general public to wear something like that in a grocery store, but that is not okay for a healthcare setting. On the right is what sort of our typical PPE situation is, at least from the neck up. So something to cover the hair, it's a good idea. You do want some sort of protection for the eyes, especially if you're going to be doing any sort of procedure at all. It's important to have a mask or face shield of some sort. And then an N95 mask is needed to be able to reduce the risk of breathing in those aerosols. And then a lot of places are doing what I have shown here, which is having a surgical mask that you can put over the N95 because there's such a severe N95 shortage. I think most places people are usually just getting one per shift, maybe. That's the situation for us for the most part. We get one per shift unless there's something that gets really soiled. And then you can put the surgical mask over that and switch that periodically in order to decrease the risk of cross contamination between patients, particularly if you do any sort of procedure where there's any sort of spray. But just coming back to this cloth mask question, because this is something that's been coming up. There is research to show that cloth masks are not effective in preventing infection. So this is from a few years ago, not necessarily looking at COVID, but looking at other types of respiratory infections. They randomized people. This was at a hospital system with a large number of participants. I think there was 1,000 in the study. They randomized people to either cloth masks versus control, which was just usual, just do whatever you usually do, versus medical masks. And giving people the instruction to wear cloth masks versus just do whatever they would do otherwise increase their risk of getting respiratory infections. So cloth masks are definitely not an evidence-based intervention in order to prevent healthcare workers from receiving infection in the line of work. So then there's the question, if we're talking about medical type masks, what is the use of different medical type masks? So the question of surgical masks versus N95 masks, I know has been coming up at a lot of institutions. Surgical masks are really going to be more effective at preventing the individual that's wearing them from infecting someone else. They are not going to be so effective at preventing the person who's wearing them from contracting COVID, from being exposed to the virus. So if you want to protect yourself, that is that then you should wear an N95 mask. Surgical masks would be something that I would recommend putting on all of the patients that walk into your department. Most places aren't allowing visitors anymore, but certainly if you have visitors, I would everyone in that room should be wearing a mask so that we can decrease the risk of transmitting virus if someone sneezes or coughs while they're in the department, given that we have a real limitation of airborne isolation rooms. I know I'm talking a lot about PPE, but I just know it's such a big issue with COVID and the emergency setting. So I think that it's really important for us to be careful about donning and doffing PPE. You have to be really careful about washing your hands before you put any sort of mask on. I'd recommend, again, if you're doing a procedure that involves any sort of spray, intubation, anything like that, you really need like a face shield or something that's going to actually protect your face in a full way. And then a place that people might get a little bit more casual sometimes is removing personal protective equipment. Take your gloves off first. Sorry, I'm getting a request to speak closer to the mic. Try to a little bit louder there. So make sure to take your gloves off first. Wash your hands before touching the mask, um, and you should really remove the mask from the back. We all need to watch out for each other during these times, so it's really good to have people have a practice of observing, physicians, nurse, whoever is on your team, of observing one another. And if you see anything that is a violation of best practice for PPE, we want to have a culture where we let each other know and recognize that that's a way of taking care of each other. Um, and a number of places that are dealing with high loads of COVID patients are doing things where they'll establish parts of the team to be clean or dirty. So if you have a code that you're running, for instance, then you might want to establish who's going to be in on the code, who's going to be wearing a PPE, and then to have other people who are not wearing PPE who are acting as runners in order to minimize the cross contamination between the area and the rest of the department. And again, I know this is basic, but we just got to remind ourselves, wash your hands before you put the PPE on, and wash your hands during the removal, after the removal. So this is another question that I think is coming up certainly a lot among emergency providers, but probably a lot amongst anywhere where people are still having in-person patient encounters and are dealing with mask shortages. So the question of, can we clean and disinfect N95 masks? So officially, I cannot recommend that as a practice, and officially I would say it is the best thing if you are provided N95 masks as needed for your encounters. But I recognize that that is not the situation that everyone is in as far as having access to all of the resources that we need. And so many places people are saving and want to be able to reuse their N95 masks. So this is some research from Stanford where they looked at what the N95 breakdown was using different methods of cleaning and disinfecting. They found that using alcohol solution was definitely not recommended. Basically using some cleaning solutions, alcohol or chlorine really seemed like it reduced the effectiveness of the mask. The ones that they ended up saying were the best as far as not reducing the filtration efficiency was hot air at 75 degrees Celsius for 30 minutes or ultraviolet light. Again, I cannot recommend this officially, but unofficially, what I know that people are discussing is using hot air, maybe in an oven. Although if you were to do this not recommended thing, you would want to make sure that you are not having the mask touch any metal surfaces inside the oven. So people would recommend hanging it off of another surface so that it wouldn't actually be physically in contact with anything. Ideally, of course, we will all have our N95 masks as needed, but in the real world, people might need to make some other plans. This is another thing that's kind of come up is just the concern for contamination of equipment and whether or not we should be bringing our stethoscopes. I can say personally in the emergency department, I have stopped bringing my stethoscope to work. We're seeing a lot of COVID. I would just say, use the reusable stethoscopes. And if you don't actually need to listen to the lungs, which you often don't, I would just find other ways of assessing the patient's respiratory status. There's plenty of other ways to do that, just speaking in full sentences, breathing comfortably. There's other ways to oxygen saturation. There's certainly other ways to address that issue. And the reason that I'm emphasizing this safety component so much is I think that we all know that working in an emergency department during this time is obviously a high risk endeavor. So as of today, as of just last I checked was an hour ago, they're keeping track of all the physicians that have died in Italy, and there's been 66 physicians that have died during the COVID. And we know we've started to see some deaths already in the United States as well. We're a little bit behind Italy as far as the spread, but not too far behind. We are starting to see healthcare workers die. I believe the first healthcare worker in New Jersey died this week. I think it was a custodial staff who are obviously at very high risk. So we need to be making sure that we're being mindful of the safety of all staff members as we're facing this pandemic together. So this is just a quote that some of you have probably seen, but I think it's a really important thing for us to consider right now. So this is the idea that there is no emergency in a pandemic. This is something that was written by an Army medic and Ebola responder, and something for us to consider when we're going into a patient who might be crashing. I think our typical first response is to just want to jump on in, help immediately. And that is, of course, a noble response that under normal circumstances would probably be the right thing to do. You have someone who seems like they have an overdose and they need naloxone. You might want to just run in there and give it to them right away. I think that we need to assume right now that everyone is potentially infected, especially anyone who seems like they're critically ill, and to not go into a patient area or a patient encounter unless you have the personal protective equipment you need in order to be able to stay safe. Because your life is very valuable as far as being able to extend the lives of many others. So I think we know that even if we're taking all of the proper measures, that some of us probably are going to get infected. New Jersey State is doing a great job of sharing information as far as places to get tested. They've established a COVID-19 hotline, which is being run out of the Poison Center. So I've been helping to answer some of those calls. They have been quite busy, but they are here to help if you have questions about COVID-19. And one thing that's been coming up a lot is where first responders, frontline providers can get tested. And so this COVID-19 information page does have information about testing, and it specifically will list places that have special days or fast track lanes for medical staff, frontline providers. So that's probably useful information for some of you who might be wondering about where you would have the ability to go and get tested yourself, should that come up. Okay, so now we're going to get a little bit more into the opioid specific content. Again, I think at this point we just have to assume that everyone could potentially be infected. And when we're thinking about our patients with opioid use disorder, there's a lot of reasons to think that this patient population is going to be higher risk, just given their comorbidities. Many of them are also smokers. We know that there can be cardiac complications, but I think some of the most compelling reason to be concerned is just knowing that there can be high risks of pulmonary complications in this patient population. So patients with opioid dependence are more likely to develop COPD, for instance, than patients who are non-opioid dependent smokers. And those that have COPD, that already have that diagnosis, and use opioids are more likely than individuals that don't use opioids in order to come to the emergency department for COPD exacerbations. They're more likely to be hospitalized for pneumonia, and they're more likely to die from pneumonia. And those that have opioid use disorder that are intubated for non-pulmonary reasons, so this is research from the surgical literature, it's more difficult to wean them from the vent, so they tend to have more post-operative pulmonary complications. So this is just a smattering of literature. There's other research out there, but this patient population is high risk from a pulmonary complication perspective, which I think means that they could potentially fare poorly during this COVID epidemic. I haven't been able to find any literature specifically addressing this patient population, which isn't surprising because this is such a new issue. But this does seem like something that's potentially ripe for research if you have people out there that are listening and interested in wanting to get involved in research on this. Just when we're thinking about pulmonary complications, I figured I would just throw a couple images in there of what we might see. And I don't know if some of the people from different parts of the state may not have seen high numbers of these cases yet. Again, during the Q&A session, love to hear from people about what their experiences have been. But this is just one of the many COVID X-rays that's been published. This is a case from Taiwan, and this is all the same patient showing the disease progression. So each of these X-rays is a few days apart, so you can see some worsening and then a little bit of resolution. So A is the initial one, D is the final one, and I think this was over maybe a week and a half that they took these X-rays. So this is the same patient looking at some of their CT scans findings. Not necessarily as much of a time lapse here, but you can get a sense then for what the appearance is like. So again, for both of these, we're thinking about bilateral, patchy, kind of ground glass opacity as being the typical appearance, and the CT findings can be quite dramatic in some cases. I've seen a few where it just looks like practically white out lung. So relevant specifically again to our patient population, I think that we need to think about opioid withdrawal and managing it aggressively as both for something that's good for the patient for comfort, but also as an important measure to reduce transmission, because we do know that there can be fecal shedding of the virus, of the coronavirus. So we want to do anything we can in order to decrease that being a problem. So I would recommend, I would always recommend treating withdrawal aggressively, but I would definitely recommend it right now for everybody's safety in the department or anyone who might be sharing a bathroom with those patients. Important to address the diarrhea and vomiting that could be coming along with opioid withdrawal. And also worth mentioning that there's more research now about COVID-19 presenting with GI symptoms, which just might provide a little bit of diagnostic confusion sometimes in this patient population. So I would say that if you have someone who you think is withdrawal, to just keep in mind that COVID can present with GI symptoms, and also vice versa, that you know, just think about it. Okay. So we're thinking about how to approach this patient population in the emergency department during this pandemic. We would think that, as I mentioned before, these patients are probably going to be high risk for poor outcomes related to the comorbidities that they have, and just the degree of pulmonary complications that we can see in this patient population, as well as other substance use that could put them at higher risk. So if they have smoking, additionally, obviously, it's going to put them at increased pulmonary risk, or use of stimulants can put them at increased risk for cardiac complications, which we know we're seeing also with COVID. So there's a lot of reason to think that substance use and COVID-19 are going to be a very deadly combination. But beyond even the sort of physiologic reasons to be concerned, there's a lot of sort of social reasons that they might be at increased risk as well. Obviously, there's a lot of homelessness in this patient population. That is going to complicate any sort of ability to do social distancing if they're trying to reduce the risk of getting infected. And it's also going to complicate any sort of efforts at isolation and quarantine for people who are infected. And beyond the issue of homelessness, there's also the issue of having contact with different settings that could increase risk for transmission. So a lot of these patients end up spending times in jail or prison, and jail and prison have been historically places where infectious disease burden has been high. And I know that we're starting to see some outbreaks in jails in the United States, and I know that there have been other places where they've actually released prison populations in response to this pandemic. So I think that the combination of homelessness and incarceration probably is going to put this patient population at really high risk for getting the disease. And then, as we discussed, they'll be at risk for having lots of complications from the disease. So again, I mentioned earlier, we should treat withdrawal aggressively in order to limit exposure. And we want to do that both in the department, and then we also want to think about that when we are discharging this patient population from the emergency department. So I would say usually when I'm telling my colleagues about how long they should, those that are X-waivered, should give as far as number of days for buprenorphine, I usually want people just to cover them until they think that the patient is going to be able to follow up. And usually we're hoping that's going to be within a few days or a week.
I would say that right now, it's probably better for everybody to give a little bit of a longer prescription. I can't say exactly how long that's going to be because it's going to depend a bit on what the situation is, the follow-up situation at your institution. But I would lean towards longer durations of prescriptions right now, just because if the more that we have this high risk patient population going back and forth between emergency departments and homeless shelters, for instance, the more at risk we are all going to be for this being a public health problem, more than it already is. Um, the other thing to think about is if you have a patient that you are discharging with a suspected or known COVID diagnosis, and you are recommending that they isolate or are being put into quarantine, it's really important to have a plan for those that are dependent on opioids for them to be able to access their medication-assisted treatment to get their buprenorphine or their methadone, because if they don't, they're not going to follow quarantine. It's just like the withdrawal symptoms are going to be uncomfortable. People are going to go out. They're going to either look for their, to try and get their substance, or they're going to come back to the emergency department. We really have to be proactive about addressing this. Otherwise, the risk for people not following their um, isolation recommendations is going to be high. The other thing too is that we should be screening people for homelessness when we are discharging them, with recommendations to isolate, because if you're homeless and you don't have a place to isolate, um, that's a problem. I mean, it's always a problem when people don't have a place to stay, but it's more of a problem for everybody right now, because if they don't have the ability to safely and effectively isolate, then it becomes more of a public health risk. So we need to be more aggressive than usual right now about addressing issues related to medications for addiction and addressing housing, because there's a real compelling risk to everyone, including frontline providers, if we don't address those things proactively. There is some good news just as far as the ability to facilitate care for people. So this is actually just hot off the presses. I think they just sent this out yesterday or this morning. The DEA is relaxing telemedicine regulations. So they had previously, in response to this public health emergency, said that they would allow telemedicine in lieu of a in-person encounter, but it was still not totally clear whether they would allow just phone encounters for new patients. It seemed like the recommendations were that it had to be a video encounter for a first visit, and then telephone was going to be allowed after that. But they have now said that they will allow telephone encounters as the first encounter, without an in-person or video telemedicine encounter, in order to prescribe buprenorphine. So this is going to make it easier for us to coordinate with our addiction colleagues or whoever else that we have relationships with that are prescribing buprenorphine. So if you're not waivered, or you don't necessarily want to use your waiver for a long time, for a longer duration of prescription, then this is an option in order to be able to get people some prompt follow-up. If you can build relationships with someone who has a waiver and is willing to have a phone call with the patient, then you're going to have an easier time being able to get them a script, assuming the patient has a reliable phone number, which of course is a separate issue. Um, okay, so this is coming back a little bit more to the public health implications of this pandemic. So I think we probably were all aware that there was already a really scary exponential growth related to opioid deaths. Started with the prescription opioid epidemic, and then grew into the heroin epidemic, and then grew into the fentanyl epidemic from there. So we've been seeing a lot of increase in deaths related to this problem. And then if you overlay that with the COVID-19 pandemic, and all the reasons that we think that this patient population is going to be at risk, this just seems like the sort of thing that could be just catastrophic for this patient population from a public health perspective. And I'm going to come back to this point, which I've already made a little bit during this lecture, which is that this situation really ties all of our fates together. So the worse this problem is from a public health perspective, the more physicians, frontline providers, EMS, the more all of us are at risk. The more COVID infected patients that come into our department, the faster they come, the fewer ventilators there are when people need them, the more healthcare workers are going to be infected. We are all in this together, and we are really only as safe as our most vulnerable patient population during this time. People don't have ways to isolate, protect themselves, then they're going to be showing up in our department needing assistance. And so this is a problem, particularly with homelessness. This is just an image from Las Vegas. A homeless shelter had to get shut down because of a patient who was positive there. And what ended up happening was just like hundreds of people sleeping in a parking lot. And we might see more issues like this. Shelters tend to be crowded. They're not really safe spaces for people to isolate. And so we're probably going to have to come up with some alternate housing plans collectively in order to be able to address this issue in a robust way that's going to keep all of us safe. So, and again, same issue with jails as with shelters. These are going to be places where there could be crowding, rapid spread, and so there has to be some consideration of addressing these patient populations that are spending time in like ICE facilities and shelters, in jails and prisons. We don't make plans on the front end, like as soon as possible to start figuring out how to allow social distancing and isolation in these facilities. We're going to be seeing a lot of these people come through our department. So with so overall, I think most of us are probably familiar with these, but there's some general overview of measures to flatten the curve of spread. Again, personal protective equipment for healthcare workers, really, really super important. We all need to be advocating for that. And obviously hygiene, social distancing for everybody, including us. And increased testing is going to be important. There has been some good news, at least as far as increased testing availability at our institution. They just rolled out at the beginning of the week a rapid RNA PCR test. So that's good news for us. There are more testing centers that are showing up across the state and the country. And again, NewJersey.gov has a nice summary of testing centers that you can figure out where there's a center that's close to you. Isolation and quarantine of suspected or confirmed cases. And I didn't talk about this too much already, but it's worth mentioning that none of the tests are perfect, and there can be problems with sensitivity related to the method of specimen sampling. And also related to what point in illness the person is. So if the person has a high, they're like have a high viral load, they've got a lot of that viral RNA floating around, and they get a good deep nasal swab, then you're going to be more likely to get a positive test. A negative test does not necessarily rule someone out, and so we're still going to have to be cautious about people who have symptoms that are consistent, about recommending common public health measures like isolation and quarantine, even if we're not sure in some cases, especially in scenarios where we're thinking about sending someone back to a place where there's a high public health risk, like a jail or shelter. We should really be cautious about doing that and keep in mind tests are not perfect. Telemedicine, obviously super vital right now. And as much as we can try and bring that in, everybody should be trying to figure out how to scale up telemedicine, whether that's to decrease people from even showing up in the department in the first place, in the emergency department. That's great, as much as we can do that. And as well as with our follow-up with our colleagues in other specialties. But using telemedicine is going to be very very important in this time. And I don't usually advocate praying, but right now, pray for a vaccine. Let's hope that comes soon. Okay, and then relevant to this patient population, um, we're thinking about vulnerable patients that are have homelessness or substance use. I think that housing is really important, and it's a problem all the time that there's a lot of people that struggle with having safe and secure housing. But right now, again, because our fates are all tied together, as we've discussed, it's really vital for us to address this on like a wide scale, city, state, federal level. Like we have to make sure that housing is available for people. And we want to, if we're providing emergency housing for people, have that cohorted by suspected or confirmed COVID status. Obviously, there's a really high importance of being able to provide spaces for quarantine for people who are suspected or confirmed of being infected. But I would also say that providing housing for people who are at risk for becoming infected is also an important public health measure. So addressing the risk of jails, shelters in accelerating transmission in high-risk populations is also a really important point. So shelters need to address the crowding and work with the county or state level to try and figure out alternate ways to house people if the shelter is not a safe place to house people. And jails too. If we can't figure out ways to be able to space people appropriately, then we need to find more spaces. And there's lots of creative solutions that are happening around this right now. There's places that are taking over hotels. I know there's been some discussion in New Jersey about doing that. I'm sure there's different plans that are happening in different counties. But another possibility would be taking over casino lodging, which is, since casinos are closed down right now, dorms. We need to get creative, but we really need to be able to find spaces for people to isolate themselves. Also, as I mentioned before, when we're discharging people from the emergency department, giving a longer prescription for medications to treat addiction is wise right now. We really don't want people to be withdrawing when they're supposed to be in isolation, and then coming out with their vomiting and diarrhea to infect the rest of the world with COVID. So treat addictions aggressively. And another thing that we could consider, just as far as this particularly vulnerable patient population, is finding ways to get them phones in order to be able to facilitate follow-ups. I know at least in Newark, a lot of this patient population that I take care of doesn't have phones. So we just put in an order yesterday to be able to purchase some phones to be able to help us contact this patient population, so that we can facilitate ongoing telemedicine for them. A cheap, doesn't have to be a fancy phone, doesn't need to be an iPhone. A flip phone with a plan can cost $30-40, and can potentially save someone repeat emergency department visits. So it's definitely a worthwhile investment. So yeah, I think that I definitely wanted to leave some time for discussion and questions if people have it. This is obviously a sort of scary time to be working on the front lines, but it's also a very interesting time to be alive. I think that this is one of the most notable moments of there being a collective global experience that I can think of, where we're all sort of in this together, facing something that is quite frightening, but hopefully will bring us some opportunity to change some things about system and care that we need to change. So, okay. Does anyone have any questions, comments?
Yes.
Can you hear me?
Yeah, thank you, Dr. Fox, for that presentation. Does anyone have any questions?
I do.
Okay, perfect.
I'm from the peer recovery program, the ORP program.
Mm-hmm.
And what we do is get people in treatment, which has become a near impossibility right now.
Right.
So what we're running into is people who have any kind of pre-existing condition. And we had it today with somebody who's pre-diabetic, detoxes aren't going to take them. If they have COPD, if they have any kind of underlying health conditions right now, the detox facilities don't want to take that risk of having them come to their facility. So is there any kind of plan out there for our population that has these pre-existing conditions to get assistance? New Bridges was the only place that used to take them, but now they only take people from North Jersey, and it's a 2-week wait. And now Christ Hospital's detox is now all COVID.
Yeah, so this is tricky. I can say that we at the COE, the Center of Excellence, have been advocating for there to be in the immediate short term more spaces available that can accommodate both people who have needs for treatment related to addiction, as well as other medical needs. I wish I could tell you that I had something to offer you right now. But I can say that right now there's a lot of struggle with resources. If there's anyone else on the phone who has information about availability of resources that I'm not aware of, feel free to chime in. But I think that this is a real problem right now, and that
it's actually like we don't know what else to do with these clients, and we're trying to refer some of them to outpatient, and most of the outpatients aren't even taking anybody.
So what I guess I would say is that are these people that you're dealing with, are they homeless or no?
Some. We do have some homeless too, and the social workers are trying to figure out what to do in that case. We do some of that, but that's usually social workers. But it's the ones that, we had one guy rejected today from every single facility because he's pre-diabetic.
So I think
that's not even the worst of it,
I think that right now we're probably going to, for anyone who has a safe place to stay, we're probably going to need to try and emphasize them staying where they are, and then getting them access to telemedicine in order to be able to provide the addiction treatments and medications that they need. And then obviously, your support as a peer, or social workers, whoever else can provide emotional support over the phone. This is the good news about the DEA loosening the restrictions as far as being able to start medications. So it is possible now to start medications with a provider just by a phone call. And so if you have clinics or providers that you have relationships with, have worked with in the past, I would try and reach out to them and see if any of them are willing to start medications over the phone for people. They really should be, because there's a lot of push for people to do that. As far as finding places for people to go, it's going to be tough. And I would say if someone's not homeless right now, it's probably not the time for them to go into any sort of facility if we can avoid it if at all possible. And then, the issue of what to do with people who are homeless right now is a huge one, and I agree. It's like a thing that we are very actively advocating for radical measures to address this problem. But I think for right now, if someone has a place to stay, they should stay there. And the emphasis, instead of trying to find a place for them to go detox or to go have a rehab stay, would be to try and find someone who can help prescribe them medications in order to help them deal with withdrawal symptoms at home, and then providing support, psychosocial support over the phone.
Can I ask one question about the waiver?
Mm-hmm.
Are they letting people without the waiver prescribe? Or you still have to have the waiver?
Not right now, no.
Okay.
I would love for that part to be loosened as well, but and I'm sure there has been some consideration and discussion around it. I know I was discussing it before this all happened, but I think there's even more compelling reason now to consider it more strongly. But as of right now, they have loosened how people can use their waivers, which is great, but they have not removed the requirement for a waiver at this point.
Okay, thank you so much for everything.
Yeah, thank you. I just wanted to add to that, in terms of the loosening of the waivers, prescribers who are at different limits, like 30 there's can get a waiver to get 100 or from 100 to 275. So there are ways to do that, and we could send that information to you.
That'd be awesome. Thank you.
Does anyone else have any questions?
Other questions?
Hi, my name is Elaine Hernandez. I am the Director of Recovery Support Services for Bergen County, and I am also a consultant employee for Bergen Newbridge Medical Center. I just want to clarify something for you, Ms. Brogan, that the Bergen Newbridge Medical Center is taking patients from all the state, the entire state. We do have a limited amount of beds. We've been reduced to about 20 beds. 22 to be exact. And I know that we're taking 5 patients a day. We do have a waiting list, but we're doing our best to be able to expedite services to anybody as they come in as quickly as we possibly can. But like I said, we are limiting our ability to do so because of the amount of time we actually do have to spend per patient to make sure that they'll be okay, or to be sure enough that they're okay to be in a confined space for at least 5 days. We've been taking extra precautions to really take it easy, take it slow, make sure all the proper testing is in place to assure that they can stay on a unit with 22 people. So, so please don't keep trying. And if you do need any assistance, I will put my number in the chat box for you. To see if there's anything that we can do to help you expedite the services for that particular individual. But we are taking people with comorbidities. It's just taking us extra long to do so because we do have the confined space, which is actually smaller. We had to convert one of our smaller units because they did need to use our full detox for the COVID patients. So we've been a little bit displaced, but overall we are still accepting patients. Please, I just ask that you are patient with us. And I just want to echo what Dr. Fox had said about the importance of mitigating whether they're domiciled or not domiciled. And if they are in fact domiciled, Dr. Fox said it very eloquently in creating that telehealth relationship, and then supporting them through recovery supports is essential to their ability to navigate and mitigate what exactly it is that's going on, holistically in the world, and also, internally with their, withdrawal management and their feelings of, that concur with the substance use disorder. I'm
sorry, I don't mean to cut you off, but I did talk to the Access Center yesterday, and they told me they're only taken from Middlesex North. So you're saying that's not true?
Absolutely not true. But that's okay.
Okay.
And that's why I'm here.
Good. Thank you.
I appreciate you saying that out loud because I just want to clarify that. The other part of it is to really start that conversation too about harm reduction, because not everybody is going to want treatment at this time, and to start offering them a difference in thought process. As we continue to move forward with the substance use disorder, we want to make sure that those not interested in receiving care get the optimal education when it comes to harm reduction and the different techniques that can be put into place to perhaps prevent them from going into withdrawal, to avoid them having to go into detox if treatment is not something that they necessarily want at this time.
Yeah. Great. Thanks. Thanks so much for weighing in. Other questions, or if anyone else wants to share experiences too, it's a nice chance for us to kind of just talk about what's going on with this situation in New Jersey and what people are seeing.
Yeah, I just had a question, Dr. Fox. So with these changes in testing and things, a lot of times these patients who present with shortness of breath, who may instead maybe presenting with fever and shortness of breath, may instead have another issue like pulmonary embolism, for example, but we're treating someone instead for COVID-19 or maybe a heart failure exacerbation. From the emergency room perspective, can you talk about how,
yeah, it's
everyone's
tricky.
thinking about COVID-19 all the time, we may be missing other diseases.
Absolutely. Yeah, PE in particular is really tricky because COVID infection does seem to raise your D-dimer. And so people who have severe COVID infection with pulmonary complications usually have an elevated D-dimer. And there can be a lot of similarities in how they present. They could both be tachycardic. You can see low-grade fever with pulmonary embolism. So I will say that that is a tricky thing. I have been reminding the residents I've been working with that we do still have to consider PE when we're dealing with these patients. And I know in some other places, like in China, they did a lot of CAT scans for diagnosis, given the limitations of the test. We're not really doing that at our institution, or I think many places in the States right now. But I have been having a little bit of a lower threshold for people who have like risk factors or things like that to do a CT PE protocol, because we do have to keep that in mind. I had a couple people over the weekend who had significant risk factors for PE, but it could be difficult to tell the presentation apart. I think if you got someone who has a high fever, that's going to be more suggestive, obviously, of a COVID infection. Or if you have someone who is like sharing a household with someone else who's infected. I will say just now that because we're seeing so much, at least in my department, that is probably more likely in many of these cases, but it's important to keep our differential open for sure. Does that answer your question, Clement?
Yes. I think it all has to tie into, like, for many of these opioid use disorder patients, like you were mentioning, being able to distinguish the opioid withdrawal from the COVID-19 symptoms as well.
Right.
And that's something that I think you really emphasize a lot.
Right. Which, I mean, and that, at least from that perspective, because COVID can present with GI symptoms. But if you have someone who you're not sure, they'll probably be able to tell you a lot of times if this feels like withdrawal. But if you treat it and it gets better, you give them a dose of buprenorphine and their diarrhea improves, that's of course moves us more in the direction of that being withdrawal. But that being said, there can also be people who have limited symptoms. So I saw a bunch of people over the weekend who were there for things and visits that initially seemed like they were for other reasons, who did end up having pretty clear signs of COVID. So there's a few trauma patients who came in who had maybe had some unclear story of why they fell initially, and then got scanned and ended up having very clear COVID signs on their CAT scan. And maybe it was that they syncopized because they were sick from infection. But there have been a bunch of cases where, and I mentioned earlier, a few cases of flank pain that ended up being like they had severe pulmonary infection findings on their CAT scans on their lower lobes. So we definitely have to keep it in mind with most patients coming in right now, just because the community transmission is really high.
Mm-hmm.
But that doesn't mean we can forget about all the other things that we still need to take care of. Absolutely.
Yep. All right, we're just about out of time. Thank you very much, Dr. Fox. Does anyone have any more last minute questions that they'd like to ask?
Oh my God. Hello, can you hear me?
Yes.
Mm-hmm.
Oh, okay. Hi, this is Tanya Ahern with Mental Health Association. I haven't really heard anybody talk about precipitated withdrawal symptoms. And we have a lot of people who will not go to detox because they're being detoxed on Suboxone. By the time they get to be able to take the Suboxone, it's time to leave detox. So that also means I can't get them to go on to Suboxone through a doctor because it takes them so long before they can start that they end up using. I actually sent Dr. Zerbo, someone from harm reduction sent an idea on how we can get through that. But I was just wondering what you have to say about that.
Yeah, that's a great question. I love that question. So a few things. So if I have someone in front of me in the department, then there's a few things that we can do. So obviously there's other like adjunct medications that we can use to help relieve the symptoms. So I can give people some Zofran, I can give them some pain medication to help with the body aches. There's things that we can do to help get them more comfortable so that they can wait it out a little bit longer. And some of those medications could be used at home too. But the other thing that there's a little bit of literature on this, but it's actually more just from kind of my understanding of the pharmacology and my tox background with buprenorphine. We've been having some discussions around whether starting people on a higher dose actually decreases the precipitated withdrawal. I know there's been some historical discussions around microdosing. It seems like there's sort of like this bell curve type situation with buprenorphine, where if you started a really low dose, which is the sort of microdosing approach, then you're less likely to precipitate withdrawal. If you go to more of like a medium level dose, like 4 to 8 milligrams, that seems like a sweet spot where people are more likely to get precipitated withdrawal. But you've probably heard that if you do get precipitated withdrawal, the treatment is to give more buprenorphine. And the reason for that is that when you're giving like 4 to 8 milligrams of buprenorphine, you're knocking a lot of the, sort of colloquially speaking, you're knocking a lot of the buprenorphine off of the receptors. So you're replacing what's in there with the buprenorphine, but you're not getting maximal stimulation that's possible from buprenorphine at those mu opioid receptors. So if you start someone on a higher dose, you can actually give it to them at a lower COWS score. So if you give someone just 16 milligrams off the bat, then you don't need someone to be in as severe of withdrawal in order to do that. So I had a couple people that I did that for over the weekend. I didn't want them to hang around in the department for a long time. I really wanted them to start buprenorphine, given the risks of going out to use during these times. And so I had someone who, I mean, basically just reported to me that they had like mild symptoms of withdrawal. And I gave them 16 milligrams and they felt great afterwards. And if you 16 milligrams isn't enough, 24 is the max that you can give in a day, at least as far as like recommended. So I would say the two things then that I would recommend would be using adjunct medications in order to help relieve those symptoms a little bit. And then to consider using just like a high dose of buprenorphine initially. You'll also get some coverage for a little bit longer then, because if you double the dose, you basically get an extra half-life duration of action. And buprenorphine, when it's given sublingually, has a pretty long half-life regardless. So I would say more consideration for a high initial dose in order to decrease the risk of precipitated withdrawal.
Are you finding more symptoms of, more people having precipitated withdrawal because of the fentanyl?
No, I don't know that I am finding that. I think that there's a lot of discussion around like how fentanyl impacts things. Fentanyl, if it's of course there's fentanyl and there's fentanyl analogs. So relevant to fentanyl itself, it has a shorter half-life than heroin or other things. And so I would actually expect for there to be less risk of precipitated withdrawal with fentanyl, because you would have a shorter period before it would be safe to give buprenorphine. Now, of course, the caveat to that is that we often don't actually know all of the different substances that are hanging around in the heroin that people are taking. And so it could be that if they have something with a longer half-life, then they would have a higher risk for precipitated withdrawal.
Okay, great. Thank you.
Okay. Mm-hmm. Well, thank you very much, Dr. Fox, for this wonderful and informative presentation. At this time, no, we're out of time, but I did want to point out a couple of things. In the chat box, I provided everyone our YouTube channel a link. So if you visit that, you'll be able to get our Learning Collaborative archives. And in case someone's joined this talk that's not part of our listserv, our website for that is also on the bottom, bit.ly/COE_subscription. This concludes our Learning Collaborative sessions for now, but please, we'll send updates, announcements for future presentations via our listserv. So if you have any questions, please definitely email us at coe@njms.rutgers.edu, and we'll all keep in touch, and especially during this COVID-19 crisis, we're going to get through this. Happy April. So there's a lot of things that we can look forward to as well. So thank you very much again for everyone's time.
Thanks, everybody. If you have further questions, feel free to reach out.
Yep.
Happy to answer them.
Yes. I'll stay on a little longer in case people want to jot down the information.
And I can still hang around for a couple minutes too. I know we're closing the meeting, but if anyone has any burning questions right now, I can